Imagine a surgeon, someone whose precision relies totally on unwavering fine motor control, starting to notice a persistent tingling, maybe in their ring and pinky fingers. It's subtle at first, perhaps worse after a long surgery, or maybe after hours hunched over a microscope. Now, this isn't just a minor annoyance, it's the insidious onset of cubital tunnel syndrome, a condition that could quietly jeopardize their career and, well, one we're seeing with increasing frequency in our demanding professions. Okay, let's truly unpack this. Today, we're delving into cubital tunnel syndrome, sometimes dubbed smartphone elbow, a remarkably common yet potentially debilitating issue impacting upper limb function, particularly relevant for those whose hands and elbows are their very tools of trade. Our mission today is to cut through the noise, to move beyond just a surface level understanding, and provide you, our mid senior medical professional listeners, with clear, actionable, and deeply nuanced insights to effectively understand, diagnose, and manage this condition.
That's a perfect framing, actually, because what's truly fascinating and often overlooked even by experienced practitioners is just how pervasive this condition has become. It's not merely a smartphone elbow thing. It really is a silent occupational hazard for many.
Mm.
The real insight here isn't just knowing the symptoms list, but recognizing that subtle progressive nature that often masks its severity until irreversible damage is already set in.
Mm.
This really calls for a shift, I think, from just reactive diagnosis to more proactive vigilance, both in our own practices and for our patients.
Right. Now, when we talk about the funny bone, most of us just recall that fleeting electric jolt, don't we? A momentary tingle when you bump your elbow. But cubital tunnel syndrome is clearly far more persistent and more problematic. Professor, could you perhaps delineate for us what it truly entails and why it's so much more than just a passing sensation?
Absolutely.
Yeah.
So cubital tunnel syndrome is fundamentally a compressive neuropathy, specifically of the ulnar nerve, right at the elbow. It occurs when the ulnar nerve, which is one of the three main nerves in the arm, becomes injured or inflamed, swollen, irritated, basically compressed as it passes through a narrow, rather unforgiving passageway called the cubital tunnel.
Okay.
Unlike that brief funny bone feeling, which just resolves itself, this is a chronic, often progressive irritation, and it can lead to significant, sometimes permanent dysfunction if it isn't addressed properly. What happens is the constant pressure causes microvascular compromise, it disrupts the nerve's blood supply, and it impairs axonal transport, which is absolutely essential for nerve health and communication.
Right. The internal workings.
Exactly.
Right.
And over time, this can lead to demyelination, where the protective sheath around the nerve fibers, the myelin, starts to break down. This severely impacts signal transmission.
I see. And the nerve itself, where does it start? It's quite a long journey, isn't it?
It is indeed. The ulnar nerve has a long and intricate path. It starts quite proximally, actually. It originates from the medial cord of the brachial plexus, drawing its nerve fibers from the C8 and T1 nerve roots, right up in the neck region.
Okay.
From there, it travels all the way down the arm into the hand. Now, while the ulnar nerve can theoretically be compressed in other places along its path, say, beneath the clavicle or more distally down at the wrist level within Guillen's canal, the elbow really remains by far the most typical, the most common site of entrapment.
Oh, okay.
And that's precisely where the term cubital tunnel syndrome gets its name and its primary clinical focus.
So it's really about this specific anatomical bottleneck at the elbow. That structural overview you gave paints a vivid picture, a sort of tight squeeze for the nerve. But what truly fascinates me, and maybe where some clinicians sometimes miss the dynamic element, is how normal elbow movements, just the everyday bending and straightening, actually change the tunnel itself. Could you elaborate a bit on how these dynamic shifts contribute to the pathology, and perhaps how significant are those changes in, real terms?
You've hit on a critical point there. The cubital tunnel's architecture is almost like a design flaw waiting to happen, specifically for the ulnar nerve. Imagine this tight, dynamic passageway. The roof of this tunnel is mainly formed by the fascia of the flexor carpiulnaris muscle, the FCU fascia, and also a structure known as Osborne's ligament, which stretches between the medial epicondyle and the olecranon. Now, this roof isn't static. It can actually tighten almost like a band during elbow flexion. It acts as a primary choke point. Then beneath the nerve, the floor is composed of the posterior oblique and transverse bands of the medial collateral ligament, along with the elbow joint capsule itself. This offers very little cushioning against impact.
Not much protection.
Not much at all. And then the bony walls, the medial epicondyle, that prominent bump on the inside of your elbow, and the olecranon, the bony tip, they make it an easily bruised sort of highway for the nerve. It's this combination of constrained space, minimal protective soft tissue, and its superficial position very close to the skin that makes the ulnar nerve here highly susceptible to external impact or um, prolonged pressure.
Okay, so it's vulnerable just by its location.
Precisely. And this is where the dynamic aspect becomes so fascinating and clinically critical. Normal elbow movement, particularly flexion, bending the elbow, dramatically alters the environment within that cubital tunnel. Studies have clearly shown that the intraneural pressure, the pressure inside the nerve within the tunnel, significantly increases during elbow flexion.
How much does it increase?
Well, for instance, data suggests that at 90 degrees of flexion, the pressure on the ulnar nerve can increase by as much as 10 times compared to when the elbow is fully straight in extension. This pressure rise directly contributes to nerve compression.
10 times, wow.
Yes, it's quite significant. Furthermore, the cubital tunnel actually changes its shape during flexion. It transitions from being more rounded, a bit more accommodating, to more flattened oval shape.
Ah, okay.
And this shape change leads to a substantial reduction in its internal volume, somewhere around 55% to be precise.
55% reduction, that's huge.
It is. And this volume reduction, of course, further intensifies the pressure on the nerve, potentially leading to ischemia and mechanical deformation. Understanding this volume reduction is critical because it directly informs our clinical recommendations. For instance, 45 degrees of elbow flexion is often considered the optimal position for reducing that intraneural pressure.
Because the tunnel volume is greatest there.
Exactly. It allows for the greatest volume within the tunnel, and so it's frequently recommended for immobilization strategies, say during conservative management, or sometimes postoperatively.
That makes perfect sense. It's quite remarkable how much a seemingly simple bend of the elbow can impact such a vital structure and its long-term health. And I understand there are also certain anatomical variations, things that can predispose individuals to this entrapment, making some people inherently more vulnerable than others.
Indeed. And the critical insight from these anatomical nuances is that a sort of one-size-fits-all diagnostic approach can be a real pitfall. An astute clinician won't just look for the typical compression points, but will actively screen for these variants, especially in cases with refractory symptoms or perhaps atypical presentations.
Because missing them could affect treatment.
Absolutely. Missing these can mean the difference between, say, failed conservative management and effective surgical planning. One notable variation is something called the arcade of Struthers. This is essentially a fibrous band, a thickening of the medial intermuscular septum, and it's present in roughly 70% of individuals.
70%, that's quite common.
It is. It's located proximal to, meaning just above, the medial epicondyle. When it's present, this band can act as an additional, sometimes overlooked, site of compression for the ulnar nerve as it passes through, especially during elbow flexion.
Okay, so another potential choke point.
Precisely. Another significant anatomical anomaly, though much rarer, is the anconeus epitrochlearis muscle. This is an anomalous muscle that runs from the medial olecranon to the medial epicondyle.
An extra muscle.
An extra muscle, yes. It's found in only a small percentage of the population, perhaps 1–3%. But when it is present, it can directly encroach upon the ulnar nerve during elbow movement, contributing directly to nerve entrapment. And it often causes symptoms that are quite difficult to pinpoint without specific knowledge of this anatomical possibility.
Right.
So these anatomical nuances really mean that a clinician's diagnostic approach must be astute enough to consider these less common but potentially highly impactful structural predispositions. They can significantly influence the patient's symptoms and even dictate the most appropriate choice of treatment down the line.
So we've explored the intricate anatomy and how movement can exacerbate pressure within that, well, rather tight cubital tunnel. But what truly causes this nerve compression and irritation in the first place? Is it purely about how we hold our phones, as that smartphone elbow name suggests? Or are there deeper underlying causes and lifestyle factors that clinicians should really be aware of, perhaps even within their own demanding work environments?
That's an excellent and very pertinent question, and you're absolutely right. It's far more complex than just smartphone use, although that is undeniably a very common and probably escalating trigger in modern life. The causes of cubital tunnel syndrome, broadly speaking, fall into several categories. You've got the primary mechanisms of compression and traction, then associated medical conditions, and finally, certain lifestyle or demographic factors.
Okay, let's start with those primary mechanisms then.
Right. Starting with the primary mechanisms, prolonged elbow flexion is a major culprit. When the elbow is bent for extended periods, imagine cradling a phone between your ear and shoulder during a long call, or prolonged reading with your arms flexed, or even sustained desk work postures, like continuous mouse use with the elbow resting maybe on a hard surface.
Things many of us do every day.
Exactly. This puts direct tension and compression on the ulnar nerve. This sustained bending stretches the nerve and increases that intraneural pressure we talked about, essentially starving it of oxygen. Then there's repetitive elbow movement, particularly activities requiring both repetitive elbow flexion and a valgus stress that's an outward bending force at the elbow.
Like in throwing sports.
Precisely. Common in throwing sports like baseball or javelin or certain occupations involving repetitive overhead movements, maybe painting or carpentry. These repeated motions can lead to chronic microtrauma and inflammation around the nerve.
Okay, what else?
External pressure is another ubiquitous cause.
Yeah.
Just leaning on hard surfaces for extended periods could be armrests on chairs, the edge of a desk. Even car windowsills can directly irritate or damage the nerve over time, leading to localized swelling and inflammation. Even a single direct trauma, like a sharp knock to the funny bone area during a fall or accident, can cause immediate irritation and swelling, potentially initiating the whole cascade of symptoms.
Right.
In some individuals, the ulnar nerve itself can actually be unstable. It might visibly slide out from behind the medial epicondyle when the elbow is bent. Sometimes you can even hear or feel it snapping over the bone.
Oh, really?
Yes, it's called subluxation. This repeated sliding back and forth causes chronic irritation and friction on the nerve over time. And finally, fluid buildup in the elbow joint, perhaps from repetitive use or minor inflammatory processes, can lead to swelling that directly compresses the nerve within that confined cubital tunnel space.
That covers the direct mechanical stresses incredibly well. But what about underlying medical conditions or even past injuries? Are some patients sort of predisposed because of other health issues, creating a fertile ground for cubital tunnel syndrome?
Absolutely. Pre-existing medical conditions and past injuries definitely play a significant role in increasing a person's risk. Sometimes they even create a structural predisposition for the syndrome. For instance, arthritis of the elbow, particularly osteoarthritis or inflammatory arthritis, can lead to osteophyte formation bone spurs or general narrowing of the cubital tunnel itself, which can directly impinge on the nerve.
Makes sense.
Previous elbow injuries like fractures, maybe supracondylar fractures of the humerus, or medial epicondyle fractures or even dislocations, can alter the normal anatomy of the elbow. They might create deformities or scar tissue that makes the nerve more vulnerable to compression later on. The presence of cysts or space-occupying lesions, things like ganglia, or rarely tumors near the elbow joint, can also directly compress or irritate the ulnar nerve.
So previous trauma is a big factor.
It certainly can be. Furthermore, acquired deformities, such as cubitus varus, where the forearm is angled inward, or cubitus valgus, where it's angled outward beyond the normal limits, can alter the nerve's tension and its path. Conditions like medial epicondylitis, often known as golfer's elbow, can create inflammation and swelling nearby, indirectly affecting the nerve.
Right.
Even a history of burns around the elbow can lead to contractures and scar tissue that entrap the nerve. And sometimes, prior elbow contracture release surgery can lead to changes that inadvertently predispose someone to ulnar nerve issues later. These factors can collectively create an environment where the ulnar nerve is just inherently more susceptible to the compressive and traction forces we discussed earlier.
Leading to a higher likelihood of symptoms.
Exactly. A higher likelihood of symptom development.
And what about broader lifestyle choices or demographic trends? Does age, gender, or even something like smoking factor into the likelihood of developing this syndrome? It really sounds like it's a multifactorial equation.
It absolutely is a multifactorial equation, and these broader factors are indeed important for a comprehensive understanding. From a demographic perspective, the incidence of cubital tunnel syndrome generally increases with age in both men and women. This probably reflects the cumulative effects of microtrauma and degenerative changes over a lifetime.
Okay.
Interestingly, females are statistically more likely to present at an earlier age, although males typically show a higher overall incidence, perhaps due to occupational exposure or maybe greater participation in certain sports.
And smoking, you mentioned that.
Yes, smoking has also been identified as a potential risk factor. Now, the exact physiological mechanism isn't fully understood, but the hypothesis is that nicotine might cause microvascular ischemia, basically, a reduction in blood supply to the vasa nervorum, those tiny blood vessels supplying the nerve itself.
Oh.
And this could hinder the nerve's ability to repair itself or recover effectively from compression. There's also ongoing discussion around body mass index, or BMI. Some studies do suggest an elevated BMI might be linked to an increased risk, possibly due to increased systemic inflammation or maybe greater general tissue compression.
But it's not definitive.
Well, it's important to note that these findings aren't universally accepted. More rigorous research is probably needed to establish a definitive causal link. Some research points to a correlation, but acknowledges that lifestyle factors often associated with higher BMI, like sedentary behavior or perhaps prolonged device use, might be confounding variables.
Right, correlation isn't causation.
Precisely. Now, this does raise an important question for our audience, doesn't it? Particularly given the inherent demands of their own professions. Considering surgical procedures often involve prolonged, precise hand and arm positioning, maybe long hours spent peering into a microscope, or even sustained postures during patient consultations. What specific activities might inadvertently put clinicians, in particular, at a higher risk for developing cubital tunnel syndrome?
That's a really pertinent point for our listeners.
It is. For a neurosurgeon, maybe it's the sustained elbow flexion and pronation while operating with a microscope. For a dentist, perhaps the specific angle of holding instruments and positioning their arm. Even for a radiologist, the sustained mouse work and screen interaction could potentially contribute. It's a relevant consideration for all of us, I think, encouraging a bit of self-reflection and maybe some proactive measures.
Okay, so moving from the why to the what, how does cubital tunnel syndrome actually manifest itself in our patients? What are the telltale symptoms and the crucial physical examination findings that we, as medical professionals, really need to pinpoint for an accurate and timely diagnosis? This is where our clinical detective work truly begins, isn't it?
Indeed it is. The clinical picture of cubital tunnel syndrome is generally quite distinctive. It primarily revolves around sensory and motor impairments in the hand and forearm, reflecting that ulnar nerve distribution.
Let's start with the sensory side. What do patients typically report?
For sensory symptoms, patients most commonly report paresthesias. That's a sensation of numbness or tingling, often described as pins and needles, or maybe an electric feeling. This typically occurs in the small finger, the ulnar half, the little finger side of the ring finger, and frequently the ulnar dorsal aspect of the hand as well, the back of the hand on that side.
And is it constant?
Initially, these symptoms are often intermittent. They come and go, perhaps triggered by certain activities or positions. However, as the condition progresses or becomes more severe, they can unfortunately become constant and quite debilitating. Patients will often describe it as their fingers falling asleep, particularly when the elbow is bent.
Which activities tend to bring it on?
Well, the sensation is notoriously exacerbated by activities requiring prolonged elbow flexion. The classic example is holding a mobile phone during a conversation, hence smartphone elbow, but also engaging in extended desk work like typing with elbows propped up or even driving with an arm resting on an open car window for a long time.
Right.
A classic nocturnal symptom, which is often a key diagnostic clue, is waking up at night with numb fingers. This often happens because individuals unconsciously sleep with their arms flexed, which, as we know, increases pressure on the nerve.
And is there pain involved too?
Yes. In addition to the paresthesias, patients may also experience a dull aching pain, typically on the inside of the elbow. This pain can sometimes radiate proximally up the arm or distally down into the forearm and hand, and it's often aggravated by activity.
So it clearly starts with sensory changes, which can be quite disruptive, but does it then progress to affect strength and function more significantly? And what are the implications if it does?
Absolutely. The progression to motor symptoms is a critical indicator of increasing severity and actual nerve damage. In the earlier stages, patients might experience subtle but still impactful weakness. This often manifests as a weakened grasp, primarily due to a loss of flexion power at the metacarpophalangeal joints, the empty joints. This affects their ability to make a strong fist.
Okay.
There's also often a noticeable weakened pinch, specifically a loss of thumb adduction. That's the ability to bring the thumb powerfully across into the palm. This could be quite significant, actually. Loss of thumb adduction alone can account for as much as 70% of overall key pinch strength.
70%. That's huge for daily function.
It really is. It makes everyday tasks like gripping keys, opening jars, or even just holding a pen securely incredibly difficult.
And in later stages?
In later, more severe stages, if the compression is prolonged and significant, patients can develop constant numbness and, crucially, visible loss of muscle bulk. We call this atrophy. This muscle wasting is particularly noticeable in the intrinsic muscles of the hand, specifically the interosseous muscles, those small muscles between the bones in the hand that control finger spreading and closing, and also in the first web space, that fleshy area between the thumb and index finger, which is supplied by the adductor pollicis muscle.
You can actually see the wasting.
Yes, in advanced cases, you can see it quite clearly.
Yeah.
As the condition advances further, you might also observe a characteristic deformity known as claw hand, specifically affecting the ring and small fingers.
Claw hand. Can you describe that?
It occurs due to the paralysis of the ulnar nerve innervated intrinsic muscles. That includes the adductor pollicis, the deep head of the flexor pollicis brevis, the interossae, and the third and fourth lumbricals. This imbalance causes the MP joints to hyperextend and the interphalangeal joints, the finger joints, to flex, creating that claw-like appearance in the fourth and fifth digits.
That sounds quite devastating functionally.
It is. This claw hand isn't just a visible deformity. It represents a devastating loss of fine motor control and power. It signaled the paralysis of crucial intrinsic muscles, like the adductor pollicis, which is responsible for so much of our thumb pinch strength, and the interossae, which give us the dexterity for things like writing or handling instruments. And it's vital, absolutely vital to know here, that once severe muscle wasting develops, particularly significant atrophy, it is generally considered irreversible.
Irreversible.
Irreversible. This really underscores the profound importance of early diagnosis and intervention to prevent such permanent damage.
That's a powerful and indeed sobering point about irreversibility. Given these progressive symptoms, then, what are the key clinical signs and special tests that medical professionals should specifically look for during a physical examination? To confirm the diagnosis and assess the severity, what are those specific maneuvers that truly help us pinpoint the problem?
Yes, there are several highly valuable clinical signs and provocative tests that really guide our assessment and help confirm our suspicion.
Okay, what's first?
Firstly, tenal sign is paramount. A positive tenal sign over the cubital tunnel is elicited by gently tapping or percussing the ulnar nerve at the elbow, precisely in that cubital tunnel groove. If this tapping reproduces or significantly exacerbates the patient's sensory symptoms, the numbness and tingling radiating down into the small and ring fingers, it's a strong indicator of ulnar nerve irritation right at that specific site.
Right, tenal's at the elbow. What else?
Then there's the elbow flexion test. This involves holding the patient's elbow in maximal flexion, typically with the wrist held in extension for a sustained period. If the patient's symptoms are reproduced or exacerbated after holding this position for, say, more than 60 seconds or sometimes up to 3 minutes, it's considered a positive test for cubital tunnel syndrome. It basically mimics those activities, like holding a phone, that patients often report as provocative.
Okay, those seem quite direct. What about signs of muscle weakness?
Yes, beyond these, we look for more subtle signs reflecting that intrinsic muscle weakness we discussed. The Froment sign is a classic example. You ask the patient to perform a key pinch, essentially. Hold a piece of paper firmly between the thumb and the side of the index finger. If the adductor pollicis muscle, which is innervated by the ulnar nerves, is weak, the patient will compensate. They'll flex the interphalangeal joint, the IP joint, of their thumb using the flexor pollicis longus muscle, the FPL.
Which is innervated by a different nerve.
Exactly. The FPL is innervated by the anterior interosseous nerve, or AN, a distinct branch of the median nerve. So this compensatory IP flexion is a positive Froment sign, indicating ulnar nerve weakness.
Interesting compensation.
Very. A related sign is the gene sign. This also occurs during that key pinch attempt. If the adductor pollicis is weak, the patient might compensate differently by hyperextending their metacarpophalangeal joint, the MCP joint, of the thumb. This is often coupled with thumb adduction, primarily using the extensor pollicis longus, or EPL muscle, which is radial nerve innervated. This indicates a loss of the adductor pollicis's normal function in IP extension and thumb adduction.
Okay, so 2 pinch-related signs. Are there others?
Yes, the Wartenberg sign. This refers to a persistent abduction, a drifting away, and slight extension of the small finger when the patient tries to adduct it to bring it close to the ring finger. This happens because of weakness in the third palmar interosseous muscle and the small finger lumbrical, both ulnar nerve innervated muscles that help adduct the finger. Their weakness allows the small finger to sort of drift away from the others due to the unopposed action of radial nerve muscles.
Ah, I see. The drifting little finger.
Exactly. Then there's the mass sign. This describes a flattening of the palmar arch and a loss of the normal elevation of the ulnar side of the hand. This is due to weakness in the opponent's digiti quinti muscle and decreased small finger MCP flexion, reflecting that intrinsic muscle atrophy and loss of the hand's natural arch structure.
More subtle signs of wasting?
Quite subtle, yes. And finally, Pollux sign. This indicates an inability to flex the distal interphalangeal joints, the DIPJs, of the ring and small fingers. This points specifically to weakness of the flexor digitorum profundus, or FDP, muscles to those digits, which are also supplied by the ulnar nerve.
Affecting the fingertip bending.
Precisely. What's really fascinating here is how these specific signs offer quite a precise window into the extent and the pattern of the nerve damage. They are invaluable tools guiding our clinical assessment, helping us understand the severity and the progression of the condition, and ultimately enabling us to make much more informed decisions about patient management. Understanding which of these specific muscles are affected really guides our assessment of severity and can help predict the likelihood of functional recovery, underscoring that urgency for intervention, particularly if motor signs are present.
Right, moving from the what to the how of diagnosis beyond the clinical symptoms and that detailed physical examination you've just outlined, what diagnostic tools do we as medical professionals really rely on to confirm cubital tunnel syndrome? And crucially, how do we differentiate it from other conditions that might mimic its presentation? This is where the diagnostic maze can truly begin for a clinician, can't it?
You've hit on a critical point there, absolutely. Distinguishing cuts from its mimics is paramount to avoid misdiagnosis and potentially inappropriate treatment. While the clinical evaluation remains the undisputed cornerstone, objective diagnostic tools are really vital for confirmation, for establishing severity, and for precisely localizing the site of compression.
So the clinical picture comes first.
Always. Let's just reiterate the paramount importance of a thorough clinical evaluation. It truly is the foundation of everything we do. We focus on those specific sensory changes in the ring and little fingers, look carefully for evidence of intrinsic muscle weakness, observing subtle atrophy or weakness in specific ulnar innervated muscles like the intrathigh or adductor pollicis, and as we discussed, looking for a positive tanal sign specifically at the elbow. The presence of paresthesias in the small finger, coupled with associated muscular atrophy, are particularly significant indicators, often suggesting more advanced nerve compromise. It's also absolutely crucial to compare the affected limb to the contralateral unaffected limb. This helps identify even subtle signs like interosseous and first web space atrophy or early clawing, and allows us to meticulously map out any decreased sensation in the fourth and fifth digits.
So the clinical picture paints a strong suspicion and helps us localize it to the elbow. What then is the next definitive step to really confirm that suspicion and understand the nerve's physiological health, the extent of the damage?
That's precisely where electrodiagnostic testing comes in, specifically nerve conduction studies, NCS, and electromyography, EMG. These are generally considered the gold standard. These tests play a vital role. Their primary purpose is really threefold. First, to objectively confirm the diagnosis of cubital tunnel syndrome by demonstrating impaired nerve function. Second, to help establish a prognosis for recovery by assessing the extent of nerve fiber damage, whether it's demyelination or axonal loss. And third, crucially, to differentiate it from other neuropathies that might present similarly but actually originate elsewhere, like the wrist or the neck.
Okay, so NCS and EMG, how do they work broadly?
Well, NCS are particularly useful in this context. They measure the speed and the strength or amplitude of electrical signals traveling along the nerve. It's critically important to note, and this is a key point for testing, that more accurate measurements of ulnar nerve conduction velocity across the elbow are obtained when the elbow is tested in a flexed position, typically around 70 to 90 degrees.
Why is the flexion important for the test?
Because testing with the elbow straight, in extension, might actually underestimate the true reduction in conduction velocity across the cubital tunnel. It can potentially lead to a misdiagnosis or an underestimation of the severity, a significant clinical pitfall.
Right. So what are you looking for in the results?
Key indicators for diagnosis from NCS typically include a conduction velocity of less than 50 meters per second across the elbow segment of the ulnar nerve, especially when compared to more proximal or distal segments of the same nerve. And importantly, we also look for low amplitudes of the sensory nerve action potentials, the SNAPs, and the compound muscle action potentials, the CMAPs. These amplitude reductions signify an actual loss of nerve fibers, which is generally a more severe sign than just slowed conduction.
And the EMG part?
EMG, which is often done concurrently, assesses the electrical activity of the muscles themselves, both at rest and during contraction. It helps identify signs of denervation, meaning nerve damage supplying the muscle, and also signs of reinnervation, which indicates nerve recovery is occurring. It gives us a picture of whether the nerve injury is chronic or more acute.
Okay, that makes sense for assessing nerve function. Beyond these nerve conduction studies, is there a role for imaging, things like MRI or ultrasound, in the diagnostic process? When do you typically employ those, and how do they complement the electrodiagnostic findings?
That's a good question. While routine use of MRI and ultrasound isn't generally recommended for every straightforward case of cubital tunnel syndrome, largely because the electrodiagnostic studies are usually so effective, these imaging techniques can indeed provide additional, sometimes very valuable, information in specific situations, perhaps complex or atypical scenarios.
Gotcha.
Well, MRI, for instance, can identify morphological changes. It can show enlargements of the ulnar nerve itself, particularly at the site of compression. Or it might reveal abnormal T2 signals within the nerve, which are sensitive indicators of an irritated, inflamed, or compressed nerve in cuts. It's especially useful for ruling out intrinsic masses, like tumors or cysts, that might be causing the compression but wouldn't show up on nerve tests.
Okay, so looking for structural causes and ultrasound.
Ultrasound, on the other hand, offers a dynamic and real-time assessment, which is quite unique. It can not only identify structural abnormalities around the nerve, like those osteophytes, anomalous muscles, or ganglion cysts, but it can also beautifully visualize dynamic changes in the ulnar nerve's position during elbow flexion and extension.
Ah, so you can see if it's subluxating.
Precisely. This is particularly valuable when there's a suspicion of symptomatic nerve subluxation or dislocation, where the nerve visibly snaps out of its groove during movement. That's something electrodiagnostic studies can't directly show us. Ultrasound has actually shown quite high sensitivity in diagnosing ulnar neuropathies and can really complement the other diagnostic methods, sometimes providing a precise anatomical localization that might influence surgical planning. For instance, measuring the nerve diameter with ultrasound has also been correlated with severity in some studies.
Right. And this brings us back to that diagnostic maze, differentiating cuts from other conditions. What are the common mimics and what are the key distinguishing features that medical professionals must be vigilant about? It's often these overlaps, I imagine, that pose the greatest challenge.
This is truly a critical and often challenging aspect of diagnosis, absolutely. Misdiagnosis can lead to inappropriate treatment, significant delays in care, and ultimately worse outcomes for the patient. There are several conditions that can strikingly mimic cubital tunnel syndrome, sharing very similar sensory or motor symptoms in the hand.
Okay, like what? What's the main one to rule out?
Well, first, let's differentiate it from ulnar tunnel syndrome. That's ulnar nerve compression, but it happens down at the wrist, specifically within Guyon's canal. The key differentiating features that would strongly point towards cubital tunnel syndrome at the elbow include perhaps less pronounced clawing of the hand, a sensory deficit that typically extends to the dorsum of the hand, the back of the hand, which is usually spared in Guyon's canal compression.
Because that sensory branch comes off higher.
Exactly, the dorsal cutaneous branch comes off more proximally. Also, a motor deficit in cuts might involve ulnar innervated extrinsic muscles like the flexor digitorum profundus, FDP, to the ring and small fingers, which are supplied above the wrist. And critically, you'd expect a positive Tennel's sign, specifically at the elbow, not the wrist, and a positive elbow flexion test. These latter two are particularly telling for elbow-level compression.
Okay, so elbow versus wrist. What about issues higher up, like in the neck?
Ah, yes. Another vitally important differential is C8 radiculopathy, which involves nerve root compression up in the neck. Now, with cubital tunnel syndrome, you typically see weakness, as we mentioned, in distal phalanx, flexion of the ring, and small fingers, FDP weakness, leading to fine motor difficulties, alongside those characteristic paresthesias in the ring and little finger. In contrast with C8 radiculopathy, symptoms might paradoxically improve with shoulder abduction, sometimes called the shoulder abduction relief sign.
Oh, interesting.
Yes, and sensory symptoms in C8 radiculopathy can extend more proximally, beyond the wrist perhaps into the medial forearm. Importantly, C8 radiculopathy is often accompanied by neck pain, which is usually absent in isolated cubital tunnel syndrome, and it may involve weakness in muscles not solely supplied by the ulnar nerve.
Right, a wider pattern. Are there other mimics?
There are. Beyond these, other potential mimics include lower trunk or medial cord brachial plexopathy. This involves compression even higher up in the brachial plexus, often presenting with a more widespread pattern of weakness and numbness than a pure ulnar neuropathy.
Yeah.
We also need to consider carpal tunnel syndrome, though this is usually quite distinct as it involves median nerve compression at the wrist, affecting the thumb, index, middle, and the radial half of the ring fingers, typically sparing the ulnar 2 digits and the dorsum of the hand.
Okay.
Then there's neurogenic thoracic outlet syndrome, involving nerve compression around the clavicle and first rib. This can also produce similar upper extremity symptoms, but often has associated vascular symptoms or specific postural components. And in rarer but significant cases, we must consider motor neuron diseases like amyotrophic lateral sclerosis, ALS. ALS can sometimes present initially with progressive muscular atrophy and fasciculations that might be mistaken for a peripheral neuropathy like cuts. However, ALS typically presents with more widespread upper and lower motor neuron signs.
So quite a few potential pitfalls.
Indeed. This raises an important question for our audience, doesn't it? Particularly for those in specialties where these overlaps are common, maybe neurologists, orthopedic surgeons, even general practitioners. How critical is it to get this differential diagnosis right from the outset? And what are the most common clinical traps to avoid? I think the biggest trap is probably not thinking broadly enough, prematurely attributing symptoms to the most common cause, like cut, without thoroughly ruling out more severe or perhaps more proximally located pathologies. This can lead to significant delays or inappropriate care. A thorough history, a meticulous clinical examination, and the judicious, well-interpreted use of electrodiagnostic studies are absolutely essential to navigate this diagnostic maze successfully.
Professor, once we've navigated that diagnostic maze and arrived at a clear, confirmed diagnosis of cubital tunnel syndrome, what are the treatment pathways available for our patients? What's the initial approach, and at what point do we typically pivot and consider more invasive interventions like surgery?
Right. Once a clear diagnosis is established, the treatment approach for cubital tunnel syndrome usually follows a stepped progression. We almost always start with the least invasive conservative measures first. The overarching goal, really, is to enable the patient to use their hand and arm as effectively as possible, while directly addressing the underlying causes of the nerve compression and, crucially, preventing further damage.
So conservative first. What does that involve?
Conservative management is definitely the first line of attack. This is primarily indicated for patients who are experiencing mild to moderate symptoms, and importantly, when there's no objective evidence yet of motor denervation, meaning no significant muscle weakness or visible wasting found on examination or through electrodiagnostic studies. The good news, and this is something important to emphasize to patients, is that conservative management is actually effective in approximately 50% of cases. It provides significant and lasting relief for many individuals.
50% is quite encouraging. What are the core components?
The core components of conservative management include several things. Firstly, activity modification. This is paramount and often the most impactful element. We advise patients to consciously identify and then avoid activities that are known to exacerbate their symptoms. This means steering clear of prolonged elbow bending like those extended phone calls without a headset, avoiding resting elbows on hard surfaces, or sustained positions with the elbow sharply flexed, perhaps while sleeping or reading. For a hypothetical surgeon listener, this might mean adjusting their microscope posture or using specific ergonomic supports.
Makes sense. What else?
Bracing and splinting. A very common and highly effective technique involves nighttime elbow extension splinting. The goal here is simply to keep the elbow relatively straight, or ideally in about 45 degrees of flexion, with the forearm in neutral rotation during sleep. This prevents that excessive unconscious bending that often occurs at night and significantly increases nerve pressure.
Just while sleeping.
Primarily at night, yes. Though some patients might also benefit from using a folded towel wrapped loosely around the elbow, or perhaps soft foam elbow pads during the day. This helps to minimize excessive bending and protect against chronic irritation, particularly if they frequently lean on their elbows at work.
Okay. Are medications used?
Medications, yes. Over-the-counter NSAIDs, like ibuprofen or naproxen, can certainly be recommended for symptomatic relief. They can help reduce inflammation and pain. However, and this is absolutely crucial to state explicitly, and educate patients on steroid injections are generally not used in the cubital tunnel.
Oh, that's different from carpal tunnel syndrome. Why not?
Exactly. Unlike conditions like carpal tunnel syndrome where injections can be beneficial, there's a significant and really unacceptable risk of causing direct damage to the ulnar nerve if steroids are injected into this confined, very superficial and vulnerable space at the elbow. The nerve is just too close to the surface and too easily injured.
Good to know. What about therapy?
Physical and occupational therapy. These disciplines play a vital and often underestimated role. Therapists can guide patients through specific exercises and stretches designed to improve flexibility, reduce tension on the ulnar nerve, and promote nerve mobility. This often incorporates what are known as nerve gliding exercises, or sometimes nerve flossing.
Nerve gliding.
Yes, it involves a sequence of movements of the neck, shoulder, elbow, wrist, and fingers, designed to help the ulnar nerve move more freely and reduce any adhesions or restrictions along its path through the cubital tunnel. Therapists can also provide invaluable guidance on workplace modifications to minimize repetitive strain, improve workstation ergonomics, and help break harmful postural habits. As I mentioned, the good news is that most patients do experience significant relief from their symptoms through these conservative strategies, often within maybe 6 to 12 weeks of consistent adherence.
That's reassuring to hear for those mild to moderate cases, indicating that many can find relief without needing surgery. But what happens when conservative measures simply aren't enough? Or perhaps if the nerve damage is already quite significant, maybe with progressive weakness or severe, unrelenting symptoms? When do you typically pivot and start considering surgical options?
Right. When non-operative management fails to provide adequate relief despite diligent adherence from the patient, or importantly, when the patient presents initially with severe neurological deficits, things like progressive muscle weakness, unrelenting paresthesias, or visible muscle atrophy, then surgical intervention becomes warranted. The chief objective of surgery, fundamentally, is to prevent progressive muscle weakness and wasting, because, as we discussed earlier, once significant atrophy sets in, it's generally irreversible. At that point, the goal shifts more towards preserving existing function rather than achieving full recovery.
Okay, so what are the main surgical approaches?
There are a few primary surgical approaches, each with its own specific indications and considerations. The first, and generally considered the least invasive and often the first surgical choice, is in situ ulnar nerve decompression, sometimes just called a release.
In situ meaning in place.
Exactly. The nerve isn't moved. The technique involves making a relatively small incision, maybe 4 centimeters long, midway between the olecranon and the medial epicondyle. The surgeon then carefully identifies and releases the fascial structures that lie superficial to the ulnar nerve along the medial aspect of the elbow. This typically includes distally releasing Osborn's ligament, which forms the roof of the cubital tunnel, and the superficial and deep fascia of the flexor carpi ulnaris, or FCU muscle. Proximally, the fascia between the medial head of the triceps muscle and the medial intermuscular septum is also released.
Just releasing the tight spots.
Precisely. A critical technical point in this procedure is to avoid circumferential dissection of the nerve. Dissecting all the way around the nerve should generally be avoided to minimize the risk of devascularization, which could compromise its blood supply, and also to prevent creating hypermobility of the nerve, which could lead to new irritation or even subluxation down the line.
Okay. When is this approach most suitable?
This procedure is primarily indicated when non-operative management has failed, or, importantly, before significant motor denervation occurs. It's particularly suitable for cases of mild to moderate compression where the nerve itself does not show signs of subluxation, meaning it doesn't visibly slide out of its groove during movement. Meta-analyses and clinical studies have generally shown similar clinical results compared to the more extensive transposition procedures, but with significantly fewer complications, making it an attractive first option for many. We often see good results, maybe 80–90%, for patients presenting with intermittent symptoms and no significant denervation.
So that's essentially just opening up the tunnel and alleviating the direct pressure. What if simply decompressing isn't enough? Or maybe if the nerve is prone to that instability, that subluxation you mentioned, and keeps snapping out.
Yes, in those instances, particularly where the nerve is clearly unstable or perhaps the tunnel pathology is more complex, we might then consider an ulnar nerve anterior transposition. This is a more involved procedure. Here, the nerve is not just decompressed, but it's also circumferentially dissected carefully, of course to allow it to be moved or transposed. A key step often involves excising the medial intermuscular septum, which can be another potential site of compression. The nerve is then physically moved from its original position behind the medial epicondyle to a new, less constrained place in front of it.
Moved in front of the bone.
Correct. And there are different types of anterior transposition depending on exactly where the nerve is placed relative to the muscles. Subcutaneous transposition places the nerve just under the skin and fat, lying on top of the muscle. Intramuscular transposition places it actually within the muscle belly of the flexor pronator mass. And submuscular transposition places it deep underneath the entire flexor pronator muscle mass.
Why choose one over the other?
The choice depends on surgeon preference, patient factors like body habitus, and the specific pathology. Submuscular transposition is often considered the most robust, providing the best padding, but it's also the most invasive. Subcutaneous is simplest, but offers less protection.
And when is transposition indicated over simple decompression?
This procedure is specifically indicated when a previous in situ release has failed, or for certain groups like throwing athletes who put unique and significant valgus stress on the elbow. Also in patients who have a poor ulnar nerve bed, perhaps due to a tumor, large osteophytes, or heterotopic bone formation. And crucially, it's indicated if the ulnar nerve is visibly and symptomatically subluxating or snapping out of its groove during elbow flexion. It has shown improved outcomes for these unstable nerves, particularly in pediatric populations where the anatomy might be more prone to subluxation.
Are there downsides to transposition compared to in situ release?
Well, while its overall outcomes are often similar to in situ release for primary uncomplicated cases, it generally carries an increased risk of complications compared to simple decompression. These can include infection, recurrence of symptoms perhaps due to scar tissue forming around the transposed nerve, creating new points of compression, or even injury to the medial cutaneous nerve of the forearm, causing numbness. However, recovery of nerve conduction velocity is often seen relatively quickly, maybe within 2 weeks of this surgery, with distal latency more likely to return to baseline with earlier decompression.
Okay, so decompression and transposition. Is there a third distinct surgical option, or are those really the two main pathways?
Yes, there is a third option, though perhaps less commonly performed as a primary procedure these days compared to the other two. That's medial epicondylectomy. This technique involves decompressing the nerve, similar to the initial step in the other surgeries, but then actually performing an oblique osteotomy, essentially, removing a part of the medial epicondyle, that prominent bony bump on the inside of the elbow.
Removing part of the bone? Why?
The rationale is to effectively flatten the groove, the sulcus, where the nerve runs, thereby preventing nerve subluxation without needing to physically move the nerve anteriorly. It's absolutely crucial in this procedure to meticulously preserve the insertion of the medial ulnar collateral ligament, MCL, and to carefully repair the periosteum afterwards. Damaging the MCL could significantly destabilize the medial elbow, leading to chronic instability, which is a serious complication.
So when might this be chosen?
This technique is typically indicated for patients with a clearly visible and symptomatic subluxating ulnar nerve, perhaps as an alternative to transposition. It might also be considered for very thin patients who have inadequate subcutaneous tissue to provide sufficient padding for a subcutaneous anterior transposition, or sometimes in revision cases where other methods have failed. The primary risk here, as mentioned, is that potential for destabilizing the medial elbow if the MCL is inadvertently damaged during the bone resection.
Right. So once the surgery is done, whether it's decompression, transposition, or epicondylectomy, what does the post-operative period look like for patients, especially regarding rehabilitation? Is it a quick bounce back or a more involved, nuanced process?
Oh, it's definitely a process that requires patience and dedication from the patient,
Yeah.
and it varies significantly depending on the type of surgery performed. For instance, a simple in situ decompression might allow for immediate gentle range of motion exercises, whereas a submuscular transposition often requires a longer period of immobilization, perhaps 3 to 6 weeks, maybe in a sling or a splint, to protect the nerve in its new position and allow the overlying soft tissues to heal properly.
And therapy is key afterwards.
Regardless of the specific surgical technique used, physiotherapy and occupational therapy are absolutely essential for achieving an optimal postoperative recovery. This structured rehabilitation helps patients in regaining strength of motion, restoring full function to the arm and hand, and crucially, reducing the risk of re-injury or recurrence.
What does that therapy involve?
The rehabilitation typically progresses through phases. There's usually an initial protection phase focused on managing pain and swelling and initiating gentle range of motion. This is followed by a strengthening phase, incorporating progressive resistance exercises for the forearm and hand muscles. And finally, there's a functional phase that integrates return to normal daily activities and eventually work-specific tasks. Patients usually start to see improvements in their pain, numbness, and stiffness within a few weeks of surgery, but it's really important to set realistic expectations. Long-lasting, complete results, especially for recovery of motor function if there was pre-existing weakness, may take several months, sometimes up to a year or even longer, to fully achieve.
So patience is required.
Patience and consistent adherence to the prescribed therapy regimen are absolutely paramount. And if we connect this back to the bigger picture, the choice of surgical technique itself is highly individualized. It depends on the specific anatomy found, the precise nature of the pathology. Is it just compression, or is there subluxation too? And the overall patient profile, including their profession, their activity level, and their unique needs and goals. This personalized approach is really key to achieving the best possible outcome for each patient.
Okay, as we start to wrap up our deep dive into cubital tunnel syndrome, let's turn our attention to the long-term outlook for patients. What can they realistically expect in terms of recovery? And perhaps even more importantly for all of us listening, what can we actually do to proactively prevent this condition from occurring in the first place? Especially for those of us who rely so heavily on our hands and arms in our demanding medical professions.
Right. The prognosis for individuals with cubital tunnel syndrome is highly dependent on a few critical factors. Mainly, the severity of the compression and nerve damage that was treated, the duration of symptoms before intervention occurred, and crucially, the timing of that intervention. Generally speaking, a favorable surgical outcome is much more likely for sensory function recovery than it is for motor function recovery.
Sensory recovers better.
Yes, we often see excellent results, with resolution or significant improvement of sensory symptoms, the numbness and tingling in approximately 85–95% of cases. Numbness frequently improves, although it's important to counsel patients that this improvement can be quite slow and gradual. It can take many months, as nerve regeneration proceeds at a rough rate of about 1 inch per month.
Okay, so sensation usually gets better, albeit slowly. What about muscle weakness?
When it comes to muscle weakness and atrophy, the picture is, well, a bit more nuanced and often less predictable. Surgery generally succeeds in preventing the worsening of muscle weakness and halting the progression of muscle wasting. That's a primary goal when atrophy has already begun. But improvements in existing muscle strength are often slow and, unfortunately, can be incomplete, particularly if the weakness has been long-standing before surgery.
So some weakness might remain.
In very severe cases, especially those with significant long-standing muscle atrophy before treatment, the long-term outcome for full recovery of motor function is less predictable, and some residual weakness may indeed persist permanently.
Are there specific indicators that can help us predict a patient's likelihood of full recovery, particularly for motor function? And what about those nuances of nerve regeneration that patients might experience?
Yes, there are a few important factors that influence prognosis, often revealed through those electrodiagnostic studies we discussed earlier. For motor function, a very low motor amplitude, for instance. If the CMA amplitude is less than 10% of normal on the initial electrodiagnostic studies, or significantly reduced recruitment of motor units seen during EMG, these findings suggest a lower likelihood of achieving significant or full recovery of muscle strength. They indicate more profound axonal damage has occurred.
Okay.
It's also worth noting, just to manage patient expectations, that during nerve regeneration, patients may sometimes experience transient pain and odd paresthesias. This can be attributed to random ectopic impulse generation in the regenerating nerve fibers as they're finding their way back to their targets. It's generally a normal part of the healing process, although it can be uncomfortable for a time.
And any imaging predictors?
From an imaging perspective, some studies have suggested that an ulnar nerve diameter greater than 3.5 millimeters on the initial ultrasound scan at the elbow has been correlated with persistent symptoms, regardless of whether the patient underwent conservative or surgical treatment. This might suggest a more severe underlying pathology or perhaps more chronic swelling that's harder to resolve.
Interesting. And have studies compared the outcomes of different surgeries?
Yes, various studies have provided some insights into the comparative effectiveness, although results can be mixed. For instance, one study by Glowacki and Weiss observed that 87% of patients experience resolution or improvement of symptoms after intramuscular transpositions. Though, interestingly, they noted differences in outcomes between patients receiving workers' compensation versus other patient groups, perhaps highlighting the influence of psychosocial factors. Another prospective study by Guchens and colleagues compared medial epicondylectomy with anterior transposition. They found that medial epicondylectomy led to slightly better overall patient satisfaction scores and fewer reports of mild pain post-operatively, although there was no statistically significant difference in motor power recovery or nerve conduction rates observed between the two techniques. This suggests that maybe patient preference or specific anatomical factors might influence the choice in certain scenarios. It really underscores that it's a complex interplay of patient factors and the specific surgical technique chosen.
And what about the long-term recovery and rehabilitation post-surgery? You mentioned patience, but is it generally a smooth path back to function?
Well, it's definitely a process that requires patience and unwavering dedication, as I said. Recovery time following surgery can vary quite significantly, ranging from several weeks to many months, depending on the individual's healing capacity and, of course, the extent of the nerve damage prior to surgery. If severe atrophy was present, nerve regrowth and functional return can be agonizingly slow. Dedication to a proper physical therapy program post-operatively is absolutely crucial for optimal recovery.
Why is therapy so vital?
This therapy helps in regaining strength, restoring motion, getting function back in the arm and hand, and critically, preventing re-injury by teaching proper body mechanics and protective strategies for the future. While patients often experience initial improvements in pain, numbness, and stiffness within a few weeks of surgery, achieving those long-lasting, complete results, especially regarding muscle strength and fine motor control, may take considerably longer, sometimes up to a year or even more. Setting realistic expectations with patients about this commitment is really vital for their journey.
Okay. So, given how prevalent this condition is becoming, especially with modern lifestyles, all the screen time, static postures, how can we as medical professionals proactively prevent this condition in ourselves, given our own demanding work environments? And how can we effectively advise our patients on prevention? This feels like a really critical takeaway for all of listening.
This is a vital discussion, absolutely, particularly for those of us in the medical field, given the inherent demands of our own work. Prevention of cubital tunnel syndrome really relies on a combination of, I'd say, astute ergonomic adjustments, mindful lifestyle modifications, and proactive awareness.
Let's start with ergonomics, especially for clinicians.
Right. For ergonomic adjustments, which are particularly critical for those in occupations involving prolonged, repetitive use of their upper limbs, think surgeons, dentists, or anyone heavily reliant on computers. First, workstation setup. It's essential to adjust your chair height so your feet rest flat on the floor. Ensure your computer monitor is at eye level to prevent neck strain, which can sometimes refer symptoms, and consider using ergonomic keyboards and mice that encourage neutral wrist and elbow postures, trying to avoid sustained flexion or extension. Second, proper posture. Maintaining good posture is key across various activities. When driving, consciously try to avoid resting your arm on an open car window for long periods. When typing or examining patients, ensure your elbows aren't constantly bent beyond 90 degrees. Aim to keep them closer to that 45–60 degree range of flexion where possible. For phone use, a headset or using the speakerphone is highly recommended over cradling a phone between your shoulder and ear that puts tremendous and unnecessary strain on the ulnar nerve. Third, regular breaks. This is paramount. For any occupation requiring prolonged elbow bending, computer programmers, surgeons spending hours at the operating table, dentists in sustained, precise postures, taking frequent short breaks, maybe every 30 to 60 minutes, just to stretch, stand up, change position, is so important to alleviate that cumulative stress on the ulnar nerve. Even a quick walk around the office or the operating theater can make a huge difference.
Okay, those are practical tips. What about lifestyle changes?
Beyond ergonomics, lifestyle modifications are equally important. Avoid provocative activities. Advise patients and ourselves to be mindful of and actively avoid habits like leaning on elbows, especially on hard surfaces like desks or armrests.
A simple but incredibly effective measure is to keep the elbows relatively straight at night. This can often be achieved simply by wrapping a folded towel loosely around the elbow or wearing a soft, inexpensive, off-the-shelf elbow splint. This prevents that unconscious prolonged bending during sleep. Healthy weight management. While perhaps not a direct isolated cause, maintaining a healthy body mass index may help lower the overall risk. This could be through reducing systemic inflammation or perhaps lessening general tissue compression, both of which can impact nerve health.
And exercise. Does that play a role in prevention?
Yes, exercise and stretching can certainly be beneficial. Incorporating specific exercises for forearm and wrist flexibility and strength can help. Nerve gliding exercises, those nerve flossing techniques we mentioned earlier, are particularly useful as a preventative measure too. They help the ulnar nerve slide smoothly through its pathways, potentially alleviating minor pressure points and improving its mobility, reducing the chance of adhesions forming. Keeping the arms generally flexible and strong contributes to overall nerve health and resilience.
Anything else for prevention?
Well, awareness and early intervention are also critical. Recognize the risk factors, things like diabetes, thyroid dysfunction, or a history of highly repetitive movements both in yourself and in your patients. If early symptoms do appear, seeking medical advice promptly is essential. Timely intervention, even just conservative management started early, can often prevent further nerve damage and significantly improve long-term outcomes. And just generally, basic measures like protecting the elbow by warming up properly before exercise or repetitive movements, and avoiding falls or direct impact to the inside of the elbow near the funny bone can also help mitigate risk.
Right.
It really raises an important question for all of us in the medical field, doesn't it? How can we realistically integrate these preventative measures into our own demanding, often high-stress routines to safeguard our long-term upper limb health? It's so critical to our professions. It's certainly a challenge, but I think it's a necessary one for us to address for our own longevity and practice.
So we've certainly unpacked the complexities of cubital tunnel syndrome today, from its intricate, dynamic anatomy and varied causes, right through to its comprehensive diagnostic tools and diverse treatment options. It's become abundantly clear that understanding this condition isn't just academic, is it? It's profoundly crucial for improving our patients' lives and, as you just highlighted, perhaps even protecting our own long-term well-being and professional longevity.
If we connect this to the bigger picture, the field of orthopedics and nerve health is constantly evolving. The true value, I believe, lies not just in absorbing new information, but in critically evaluating it, really understanding its nuances, and then applying it thoughtfully to provide tailored, effective care for each unique patient we see. Remember, knowledge is probably most valuable when it's deeply understood and applied with discernment.
If you found this deep dive valuable, please do consider rating and sharing it with your colleagues. It genuinely helps us reach more curious minds like yours. Until next time, keep exploring and stay well informed.